Okay, good evening, dear students. So let's continue the same type of discussion we're doing. Okay, I have come towards the end of this type of discussion. Maybe let's see. Okay, let's do this first. Then I'll tell you what to do. Okay, let's just start from number one. Okay, just have a look. Try to reach to the diagnosis. Then we'll talk.
Sir, hello.
Yes, yes.
Sir, it is Schistosoma haematobium infection.
Yeah, Schistosoma, haematobium. Okay.
Haematobium infection, yes, sir.
Okay, so you think it's Schistosoma haematobium. Okay. Any other?
Yes, sir.
Okay, fine. Okay, I'll explain this. Okay, good. That's your answer. Fine. Anybody? Yes, Namat, that is the absolutely correct answer. This is a egg of Schistosoma haematobium. It has got a spine. Okay, it has got a spine, and that spine makes it very typical. Let me show you. This is the spine of the egg. And this parasite causes bladder or urinary bladder infection, and after it causes chronic infection, it causes metaplasia there. The normal epithelium of urinary bladder is transitional cell epithelium. It is converted into squamous cell, and it can lead to squamous cell carcinoma of urinary bladder. Because of this point, this question is very important one. See here, normally, okay, majority of the malignancy of urinary bladder is transitional cell carcinoma, but because of Schistosoma haematobium, even squamous cell carcinoma can occur. And the commonest site where it occurs inside the urinary bladder is the trigone area of urinary bladder. Yes, let's move to the second one. Okay, this is Schistosoma haematobium. This is the answer. Now please have a look there. Yes, anyone?
Sir, CML chronic myeloid leukemia.
Okay, chronic myeloid leukemia. Why did you say that?
Sir, here is splenomegaly and Philadelphia chromosome is present. There is translocation between 9 and 22.
Excellent, very good. That's the absolutely correct explanation and the diagnosis. So this is a karyotyping of a patient who is having massive splenomegaly. This is a clue for you. And look at this karyotyping, chromosome number 9. Okay, let me show you chromosome number 9 and chromosome number 22. This is the translocation between 9 and 22. Okay, and this is called Philadelphia chromosome. So this is the correct answer. Chronic myeloid leukemia, and this is a Philadelphia chromosome. Very good. Now, number 3.
Sir, it is polycystic kidney disease.
Okay, you think this is a polycystic kidney disease. Okay, fine.
Yes, sir.
Yeah. Anybody else? You are absolutely
Sir,
correct.
same.
Okay. Yes.
Yes, sir.
Okay. This is adult. Okay. Polycystic kidney disease, also known as autosomal dominant polycystic kidney disease. Now look at here. These are very typical findings. This is the cross section of the kidney. Uh, this is the specimen which is showing a lot of cyst. These all are cyst. Now some important point I like to highlight here. This patient usually presents with very high blood pressure, in this case 120 over 110, and his father was also suffering from hypertension. So this is a family history, and this is explained by autosomal dominant inheritance. Now some important points about this: the hypertension occurs in 40s or 50s years, so it is very late. And the interesting question is, why so late, isn't it? If I compare this with autosomal recessive, uh, polycystic kidney disease that occurs in children, and they usually die within the first 2 to 3 years of age. But autosomal dominant polycystic kidney disease manifests in 40s or 50s years of age, because a lot of the nephrons are still working, okay, in this disorder. That's why hypertension and renal failure occurs after the age of 40. Now, at the same time, a lot of other organs are also affected here, like they may have berry aneurysm inside the circle of Willis of brain. They may have hepatic cyst, and they may have pancreatic cyst as well. So these are some of the important information. Autosomal dominant polycystic kidney disease. Now, number 4. Anyone?
Option C.
This is D.
Option?
Option
C.
C.
Okay, Bilal Rahman is saying option C. And another, Ijaz, right? Ijaz is saying option
Yes,
D.
sir. No, sir. C. It is C.
C. Yes, this is a,
Glucocerebrosidase.
exactly, this is C. You are absolutely right. This is glucocerebrosidase. Remember the name. This is a very common question you will be asked, okay? Gaucher disease and Niemann-Pick disease. These are the two from the lipid storage disorder which are commonly asked in the exam. Now, Niemann-Pick disease caused by sphingomyelinase deficiency. Now, let me say a little bit about this. This Gaucher disease is an important type of lipid storage disorder. Now, that means there is abnormal accumulation of lipid in different organ, importantly reticuloendothelial system like spleen and liver. It will be collected in the bone also. That's why when you do a bone marrow aspiration or biopsy, we can diagnose this disease. Now, one more thing I like to highlight here, in case of children, Gaucher disease can occur, and that Gaucher disease can lead to regression of developmental milestone. Regression means those milestones which they have already developed will be lost. For example, the child already learned to walk that time at the around 1.5 to 2 years. The child is already walking. If Gaucher disease occur during the time, the child cannot walk anymore. This is called regression of milestone. And when you palpate liver and spleen, they are very big. So this is the hallmark of lipid storage disorder. Glucocerebrosidase is the answer. Good. Let's move on. See this, please.
This is, I think, sir, Herpangina virus. Infected by virus.
Okay, so you think this is Herpangina caused by Coxsackie virus. Okay, yes, you are absolutely correct, Ijaz. This is the case of Herpangina. Very nice. Okay, now let me tell you a little bit more about this, maybe for some other student. Now see this picture here. Now in Herpangina, which is caused by Coxsackie virus, you need to note one important finding. The affection of the oral cavity occurs on the hard palate and the posterior wall of the pharynx and around the tonsillar area as well. You see this, this is the hard palate, okay, and it is occurring in some of the areas of hard palate. You can clearly see here. Okay. Now this is the posterior part of the pharynx. Even the soft palate is affected and around the tonsil area. These are very painful lesion. These are painful ulceration, and there is fever as well. So fever, okay, painful swallowing, and during examination, if we see this type of ulceration, almost always, not 100% of the time, but most of the time, Herpangina is diagnosed. Now, one more thing, if this type of ulceration occur on the anterior part of the oral cavity, then we think about herpes virus infection, herpes simplex infection type 1. So there's a slight difference between the which part of the oral cavity is affected. So treatment is symptomatic and supportive. So this is Herpangina caused by Coxsackie virus. Okay, let's go to number 6.
Yes, yes, sir. B.
Yes, what is your answer?
B. Thalassemia.
Thalassemia. Okay. Okay, wait. Okay, let me listen some other answer. Anybody else? Any other student? Now, see here, I'll give a little bit hint to you how to solve this type of question. Okay. Now, this type of questions are considered a little bit difficult actually. You need to know this from the beginning. Otherwise, there is no clues, no hints, nothing, no sign, symptom, nothing is given. But still, we try to find something here. Now, which of the following is not an autosomal recessive disorder? So all of these are autosomal recessive except one. So we need to choose that. And the answer is tuberous sclerosis. This is
C.
yeah, this exactly. See, this is autosomal dominant disorder, tuberous
Dominant.
sclerosis. Okay, all others are autosomal recessive. Now, phenylketonuria is called metabolic disorder, and this is the amino acid problem. Phenylalanine cannot be converted into tyrosine in phenylketonuria. So most of the metabolic disorders are autosomal recessive. Remember this. In this list, we have Tay-Sachs disease, which is lipid storage disorder, and phenylketonuria, amino acid disorder. Both are called metabolic disorder. So they fall under autosomal recessive. So these two can be ruled out. Now, okay, the three other, thalassemia and sickle cell anemia. You must have studied in hemolytic anemia chapter. Both of these are autosomal recessive disorder. Both of them, thalassemia as well as a sickle cell anemia. One clue I'll provide you. Now, there is a very common history of consanguineous marriage in this type of disorder. And in consanguineous marriage, autosomal recessive disorder very commonly occurs. And tuberous sclerosis is autosomal dominant disorder which affects mainly the central nervous system and many other organs in our body like renal or kidney, even heart can be affected. So tuberous sclerosis is the answer. Let's move on. Number 7. Now, some questions are so easy, okay?
HPV, sir.
Exactly. Okay, almost 100% of the students should be able to answer this type of question. Otherwise, you need to work hard, okay? So this is human papillomavirus. Human papillomavirus, the most common type of wart. Now, this human papillomavirus is considered as a sexually transmitted infection also because it can cause anogenital wart. Especially, there are so many different strains of HPV which can lead to anogenital wart. If that is caused by 16 and 18, it can also lead to carcinoma of the cervix. Now, there are lots of treatment available for viral wart or human papillomavirus infection. Podophyllin is one of them. Electrocauterization is another one. Okay. Silver nitrate we can apply on those lesions. So all these are different options. So this is HPV, human papillomavirus. It's a type of DNA virus. Now, number 8. Now, in this diagram, please remember one thing: A is normal and B is the pathological, picture. A is normal, B is having problem.
Sir, I think it's carcinoid tumor.
Carcinoid tumor?
Yes, sir.
Like why you reach to that diagnosis?
Sir, because of diarrhea, sir,
Because of diarrhea.
and
Okay.
weight loss, and it is the small intestine, and the carcinoid tumor is tumor of small intestine, sir, jejunum.
Okay. So let me hear other answer also. Anybody else? I
Sir,
won't tell you
T-cell
that.
lymphoma.
Yes, Ilyas, T-cell lymphoma.
Lymphoma.
Okay. Can you explain? Can you explain why?
Sir, most probably this guy is having celiac disease because there is abdominal distension, diarrhea, weight loss because of malabsorption, and the biopsy show patent villi.
Very good. Excellent. So this is a case of T-cell lymphoma, is absolutely correct. And now I already told you, let me explain this for other students. See here, this is a normal, histology from jejunum, and look at here, where are the villi? They are flat, okay? There are no villi present. This is called subtotal villus atrophy. And if I see very carefully, in this area, there are a lot of inflammatory cells as well. So this is a case of celiac disease. And you have got a typical history here. This is a 10-year-old boy with abdominal distension, diarrhea, and weight loss. This is a typical history of celiac disease. And jejunal biopsy has confirmed that. So they are asking which malignancy is associated with this condition, and the answer is T-cell lymphoma of the intestine. You need a little bit correlation here. T-cell lymphoma. Very good. Now let's go to number 9. This is also very easy. If you have studied these things, at least once before, you can solve this.
Sir, Giardia.
Okay, you are going for Giardia. Okay, and you are absolutely correct. This is Giardia lamblia. This is the trophozoite of Giardia lamblia. Look at this typical appearance. Okay, you should never forget this. This is the typical appearance of trophozoite of Giardia lamblia or Giardia intestinalis. Now it has got two forms, cyst as well as trophozoite. Cyst is an infective form which contaminates food and water, and then we ingest it. Then it goes into the stomach with the help of acidity. And then it may go into excistation. Then when it reaches intestine, the trophozoite would come out. Now this trophozoite is the active form inside the bowel. It can adhere itself on the duodenum and jejunum area and can cause a lot of problem. Now there are two types of giardiasis, acute as well as chronic. In acute condition, there is explosive diarrhea. Okay, this is a very typical term, explosive diarrhea. There's a lot of gas formation and there is a watery diarrhea. There is no blood in the stool. There is abdominal pain because of that gaseous distension. There is watery diarrhea. This is very typical. But sometimes this giardiasis can cause chronic disease also, and that is highlighted by malabsorption, especially fatty malabsorption. and the person can have steatorrhea as well as loss of the weight. This is very typical. Now, what is the treatment of this, Ilyas? What type of therapy?
Sir,
Yes.
sir, metronidazole.
Okay. So you want to say metronidazole? Okay. Any type of
Tinidazole.
this drug can be used. Yes, metronidazole, tinidazole, okay, secnidazole. These are the important drug. And don't forget, if this question is asked, you need to talk about a bit of symptomatic therapy also, because this causes explosive diarrhea leading to dehydration. So IV fluid or enough fluid also should be included. Giardia lamblia is the answer. Okay. Number 10, a bit of similar type of question which was asked before. See there?
नहीं और बोलना नहीं मैं काम ले
This is Sir E.
Okay.
Ehlers-Danlos syndrome.
Ehlers-Danlos syndrome. So you want to go for E. Yes, you are right. This is the correct answer. This is Ehlers-Danlos syndrome because that is you know, that
Connective
runs
tissue disorder.
exactly.
Autoimmune disease.
Yes, that runs in the family as autosomal dominant disorder. Okay, actually it is
Yes.
connective tissue disorder, but not autoimmune disease. Okay, please remember that it is not autoimmune disease because in
Okay.
this condition,
Okay.
yeah, the joints, our joints and the ligaments, they are very lax. The person can bend the finger in opposite direction in this type of disorder. That is the hallmark of Ehlers-Danlos syndrome. And all others are X-linked recessive disorder. This is a very important slide, because you are getting the examples of X-linked recessive disorder here. In any other question, any one of these choice can be taken and ask the question. Like Duchenne muscular dystrophy. This is X-linked recessive disorder where, okay, of course, boys are affected here. That boy develops muscular dystrophy. That means the calf muscle are hypertrophied, okay, because of collection of fat there, and actually the muscles are atrophied. The muscle mass is atrophied in this condition, so that affected child cannot walk properly, and when he is sitting he cannot even stand. He will stand by the use of his upper part of the body. This is very typical of Duchenne muscular dystrophy. Hemophilia A or B, no need of any explanation, isn't it? These are the clotting disorder. Hemophilia A because of factor 8 deficiency, B because of factor 9 deficiency. Both are X-linked recessive disorder. And in this condition, there is deep-seated hemorrhage. Hemorrhage occur in the deeper part of the body, like in the muscle, in the joint, and inside the body cavity, rather than on the surface. This is the hallmark of hemophilia. One important point is it develops target joint in hemophilia. Mainly the knee joint is affected. Hunter syndrome, it's a type of lipid storage disorder. Red-green color blindness. This will give a lot of problem, isn't it, during the driving, and even these type of people, they cannot get the license maybe. Ehlers-Danlos syndrome, I already talked. Ehlers-Danlos syndrome. Okay, now we have a bit of time before it disconnected, so let's do one more case. See there?
Nephrotic syndrome, sir.
Okay, you want to go for nephrotic syndrome. Can you give me the explanation?
Yes, sir. Here is proteinuria and
Uh-huh.
also lipids in the urine,
Uh-huh.
and yeah, and painless cervical lymphadenopathy may be due to some infections. But due to these two clues, proteinuria and fatty casting urine, I will go for nephrotic syndrome.
Okay, so 50%, your 50% of the answer is correct. Okay, but if I consider only the question, 100% answer is correct. But we are discussing here, so you need to know which is that pathology which has caused the lesion in the kidney. Okay, just think about it. Just look at the picture. Maybe you will remember it.
Sir, minimal change disease.
No problem. In the kidney,
Left atrial.
nephrotic syndrome. Okay, nephrotic syndrome has
Yes, sir.
occurred. But look at this histopathological picture and try to think which is that disease which has caused nephrotic syndrome in the kidney.
Sir, Hodgkin lymphoma.
Very good. This is Hodgkin's lymphoma. Okay, why did you say that? Why?
The biopsy showed it in Stenberg.
Exactly. These are okay. So let's restart. We are talking about this case where is a 8-year-old boy has painless cervical lymphadenopathy, proteinuria, and fatty cast in the urine. Biopsy from the cervical lymph node is shown here. The typical Reed-Sternberg cell is shown in the histopathology. What is the possible lesion in the kidney? Now, first, you need to diagnose this case. Okay, whenever you see Reed-Sternberg cell on the slide from histopathology, the first diagnosis is Hodgkin's lymphoma. But sometimes other diagnoses may also be there, like non-Hodgkin's lymphoma, reactive lymphoid hyperplasia, and very, very rarely even in Epstein-Barr virus infection. But Hodgkin's lymphoma is the first one. Okay, and Hodgkin's lymphoma can lead to nephrotic syndrome, and that clue is given by proteinuria and fatty cast in the urine. So this is nephrotic syndrome caused by Hodgkin's lymphoma. Now, a little bit knowledge about Hodgkin's lymphoma here. Hodgkin's lymphoma, okay, are of 4 types histologically. Nodular sclerosis is the most common one, followed by mixed cellularity, then lymphocyte predominant and lymphocyte depletion. So nodular sclerosing variety is the most common one. And the classical sign and symptoms are painless lymphadenopathy, painless, and cervical lymph nodes are the most commonly affected. But generalized lymphadenopathy can occur. Spleen is also very commonly enlarged. Okay, and sometimes these patient, they can have some constitutional symptom as well, like fever and weight loss. Okay, so these are some important point about Hodgkin's lymphoma. See there. So in the kidney, it has caused nephrotic syndrome. Let's move on. This is like a spot diagnosis. Okay.
Malassezia furfur.
Exactly. Very nice. This is Malassezia furfur. This is called spaghetti and cheese ball appearance. See these filaments, these are the mycelial form. These are spaghetti, and here is the cheese ball. This is the KOS preparation from the lesion of which disease is caused by Malassezia furfur? Yes, Ijaz, which is that disease? What is the name of the condition? Anybody else?
I forget.
Which disease? Anybody? Any other student? In dermatology, we have studied this. Tinea versicolor. Okay, Tinea versicolor is the condition caused by Malassezia furfur, and this is a dimorphic fungi. So there are two important morphology can clearly see: mycelial or hyphal form and rounded or yeast form. And that's why this is called spaghetti and cheese ball appearance. Now a little bit knowledge about the disease. That disease is a very benign condition in the skin. Okay, it causes discoloration of the skin in the affected area. These are called hypopigmented patches. Now there is a no itching. Okay, sometimes a slight amount of itching may be there, and uh, even the topical antifungal drugs are enough. Okay, one or two times if we apply, that particular disease may disappear. So remember this important slide. Malassezia furfur. This is dimorphic fungi. Okay, number 13.
A. A.
Yes, yes, yes.
I think it's A.
Dennis, you're
Prader-Willi.
saying Prader-Willi syndrome, A, right? Okay. Yeah, you're absolutely right. You're absolutely right. This is A, Prader-Willi syndrome. This is a little bit difficult question. So I like you to know a bit of more knowledge here. If the deletion affects the maternal chromosome number 15, the child will have Angelman syndrome. And if it affects the paternal chromosome, the child will have Prader-Willi syndrome. All others are, wrong options. Now, let me talk a little bit about Prader-Willi syndrome. Please focus here now. This Prader-Willi syndrome is a complex genetic condition which affects many parts of the body. During infancy, this condition is characterized by hypotonia. Okay. This is typical. Feeding difficulty because of hypotonia, poor growth, okay, poor growth, and delayed developmental milestone. Now, importantly, the motor development would be delayed. Now, it has another very, very important problem, that is insatiable appetite. And as a result of this, these persons become obese very soon. And we all know there are some complications of obesity, like type 2 diabetes. So type 2 diabetes occurs in them quite early in life. Okay, and obesity, very, very important point. Now, they are mentally retarded also. Okay, mentally retarded, and they have the problem of infertility as well. So obesity, mental retardation, type 2 diabetes, infertility, delayed development during the children, hypotonia and all those things, Prader-Willi syndrome. Now share, what is the cause? About 75% of these cases occur when part of the father's chromosome number 15 is deleted. Now all of us has one chromosome coming from mother, another from father. So what's the problem here? If father's chromosome number 15 is deleted and only mother's chromosome is there, then Prader-Willi syndrome occurs. And exactly opposite way, Angelman syndrome occur. Okay, Angelman syndrome occurs exactly the opposite way. Okay, 1 minute. Let me delete this for you. Okay, fine. Okay, please go through this question now. Number 14. Okay, anybody?
Sir, ankylostoma duodenale,
Okay, ankylostoma duodenal. Why did you say that?
because it penetrates to the body and gain weight and increase in size there in the intestine. Then it sucks the blood.
Okay, some of the points you have told are correct. Okay, diagnosis is absolutely correct. This is hookworm. This is the egg of hookworm, and there are two types of hookworm: ankylostoma duodenale and Necator americanus. Now, see there, the clue is given to you. The egg is the first one. It enters into the body through penetration and then causes anemia. So let me talk a little bit about hookworm infestation now. Now, the adult hookworm, they live on the duodenal area. Now, the female hookworm passes the egg. The egg will come out in the external environment, importantly in the soil. Now, in the soil, that egg will undergo into different development. Okay. The first stage of larva, which is developed from it, called rhabditiform larva, and the second stage of larva is called filariform larva. Rhabditiform larva and filariform larva. Now, filariform larva can penetrate our skin and enter inside, especially if someone is not wearing any shoes or slipper, then only that thing can happen. Now, that's why this infestation is very common during the rural or village side, where two things are happening very commonly. One, open field defecation, and another one, the children usually, they don't like to wear any shoes or slipper. Okay, so there should be plenty of egg of hookworm in the external environment first. They should develop into larval form, and then they should penetrate. All these things are necessary for the hookworm infestation to occur. Now what will happen? After this larva enters into the blood, okay, through the soul, it will go into the veins of the lower limb, through that iliac vein, then inferior vena cava, then it reaches the right side of the heart. Okay, now from there it can reach the lung. It can reach the lung. Now it can reach the lung, okay, by rupturing those pulmonary capillary and then enters into the alveoli. Now through the alveoli, the person will cough it out and it will climb the airway and reaches the pharynx and oral cavity. Now it will be swallowed again into the GI tract. Now when it reaches the GI tract, then it will develop into adult worm once again. So there's a very interesting life cycle here, okay, because of the lung pathway. So this is hookworm. And in the duodenum, it sucks blood most of the time. Though the amount of sucking blood is very minimal, because these worms are not that long enough, they suck blood continuously. So over a period of time, if there is a heavy worm load by hookworm, it can lead to iron deficiency anemia. So the anemia which occurs is iron deficiency anemia. So I need two things for the diagnosis. One is stool examination for this egg, which you can see here, and second, iron profile study. All those iron deficiency anemia should be proven. Like what is the serum iron level, what is the serum ferritin, what is the total iron binding capacity, and if possible, you can also do CBC. Now, what is the treatment? Usama, what is the treatment of Hookworm anemia? Yes. What treatment you like to give? Any other? What is the treatment?
Albendazole plus
Albendazole
iron supplementation.
in the iron
Yes.
supplement.
Good, good. Both of you, Dennis and Izaz, are saying the same thing. Albendazole to kill that worm, and then to treat iron deficiency anemia, you give iron supplementation. If anemia is very severe, you can give blood transfusion as well. Okay, very nice. So this is ankylostomach duodenal or Necator americanus. Now let's move on. Let's go to question number 15.
Sir,
Vernix caseosa.
Vernix caseosa.
Very good. Both of them are saying the same thing, and they are right. Okay, both Namath and Ijaz both are right. This is Vernix caseosa. Now, what do you think? This baby is normal or abnormal? This baby.
Sir, it seems normal.
Okay. Now, if I only consider this Vernix caseosa, then this baby is normal. Okay, but no other information was provided. What is the Apgar score and all those things not provided? But you can answer this baby is normal because Vernix caseosa is a normal substance. It is a normal thing in case of Tom babies, and the main function of this is it will prevent heat loss from the newborn baby. So Vernix caseosa, and we don't forcefully need to remove it also. Now within few days, okay, after we take repeated bath to the baby, it will go away on its own. You don't rub the skin and forcefully remove it. That may be quite harmful. Now, in preterm baby, Vernix caseosa is usually absent. Okay, so Vernix caseosa. Don't forget the picture. Let's move on. Number 16.
Uh, Sir, I think axillary nerve.
Okay, you think axillary nerve. Okay,
Yes, sir.
fine.
Because it seems like posterior dislocation.
The axillary nerve. Okay. Any other answer? Now, can you tell me which muscles are supplied by axillary nerve? Which muscle?
Sir, he is correct, sir.
Yes, yes.
Because axillary nerve supplied a deltoid, and if deltoid is gone, there will be no shoulder movement, which causes shoulder movement. So, most possible axillary nerve
Sir,
damage are circumflex nerve.
Okay, so Raymond Bilal
and sir,
saying,
the muscles are
uh-huh.
teres minor and deltoid.
Okay, so the answer is correct. Okay, always if any question comes because of shoulder joint dislocation, if they ask which nerve is damaged, you remember axillary nerve, because this axillary nerve is present very near to the joint. Okay, it is passing through the surgical neck of the humerus, so it is right here in this area. Now, axillary nerve mainly supplies two important muscle, uh, teres minor and deltoid. Deltoid is the most important muscle there, and deltoid is responsible for abduction of the shoulder joint. And uh, that that particular, rounded shape of our shoulder is also provided by deltoid. So if axillary nerve is damaged, deltoid muscle will be paralyzed, and after the paralysis the muscle will develop atrophy, and then that rounded elevation of the shoulder is also not present. Apart from that, we cannot move shoulder properly. This is axillary nerve, very important question in many different exams. Fine, let's move to the question number 17. See there?
Sir, it's Erb's palsy.
Okay, why did you say that?
Sir, because the hand is totally like, sir, flexed, sir, I think. Yes, sir, and waiter tip like, sir, position.
Okay. Anybody else? Now, your diagnosis is correct, Namath. Yes. This is Erb's palsy. This is Erb's palsy, and a little bit, history about this type of baby. Okay. They mainly develop, a thing known as shoulder dystocia. Okay. A type of obstructed labor. So when shoulder dystocia is present at the time of birth, then the midwife or the nurse or even the doctor, whoever is assisting the delivery, they may grab, they may grab this hand or arm and they forcefully pull it. So when they do that, the upper trunk of the brachial plexus, which is made by C5 and C6 root, may be damaged, and this is called Erb's palsy. Now see there, all the typical uh, sign and symptoms are shown here. This is called Waiter's tip deformity. Waiter's tip deformity, Erb's palsy. So this is characteristic of Erb's palsy. At C5 to C6, it is damaged, which accounts for almost 90% of brachial plexus injury. Now, sometimes this Erb's palsy is just a minor type of nerve damage, isn't it? So you have studied that in orthopedics. Maybe there are different types of nerve damage. It starts from the very minor one to the big and even irreversible type of damage. Okay. Now, number 18.
think pneumonia.
Sir, pneumothorax.
Okay, wait. Dennis, yes, Dennis, you want to say something? Yes.
I think it's a case of pneumonia.
Okay, which sided pneumonia? Which lung?
I think on the left side.
You mean here, this area?
Yes. Yes. Sir.
Okay. Okay. Yes, Naimat, you want to say something now?
Sir, I think it's pneumothorax because the left side is very very black because of air accumulation, and the lung is collapsed. Whole lung is collapsed to the one area.
Okay. Okay. Any other student? Okay, I will give the
And sir, there
explanation.
is tracheal shift.
Mm-hmm.
And sir, there is tracheal shift.
Okay, good reason. Yes. Anybody else? You have some different opinion maybe? Now, let me explain this. Now, see here. This is a very typical X-ray, okay? If you see carefully here, now see this. Look at this area. This is homogeneously or uniformly black in color. I cannot see any bronchovascular marking inside this area. That means this here is present in pleural cavity. Now it doesn't look like this. It doesn't look like here. It looks homogeneously more black in color than the other side. So this is called pneumothorax. And you may be wondering, where is the lung then? Okay, if this big is the pneumothorax, where is the lung? The lung is only this structure. It is completely collapsed. This is lung now. So this type of condition is known as tension pneumothorax. Now he has picked it up rightly. This trachea has been pushed to the opposite side. Okay. Trachea is pushed to the opposite side. Not that massive amount of pushing, but slightly. So this is tension pneumothorax on the left side with collapsed lung and mediastinal shift as well. And look at the history now. They have provided a severe breathlessness and chest pain. This is typical of pneumothorax. Now, what we do, okay? So we do two particular type of management here. The first thing is put a needle in the second intercostal space on the left side, okay? Then a lot of air will pass out. Then the patient feel better, but that is not your, treatment. Your still another big treatment is coming, and that is chest tube drainage. You put chest tube, then only the patient will be all right within few days. And all other symptomatic and supportive management must be done, like oxygen. Oxygen therapy has to be provided because this is a very breathless condition. And after that, you find out the cause. What is the cause of this? Is it spontaneous pneumothorax, or is it other type of pneumothorax like traumatic one? Very important question in different exam. So tension pneumothorax on the left side. Let's move on. Let's go to the number 19.
Sir, omphalocele.
Okay, you think this is omphalocele? Okay, I'll come back.
Gastrocele.
Okay, I'll come back to you. Okay, yes. Who is answering? Can you say it?
Gastrocele.
Okay, Bilal Rehman is saying gastrocele. Okay.
Yes, sir.
I want to hear some more students. We are coming towards the end now.
Gastroschisis.
Gastroschisis. Okay, why gastroschisis? Can you give me reason?
Because it's different from omphalocele. Omphalocele is when the abdominal contents are still covered by the peritoneum, but gastroschisis is there's no covering of the organs.
Gastroschisis, sir.
Exactly, very good. Okay, it's gastroschisis. Yes, it's
Yes, sir.
gastroschisis, and yeah, Derek has clearly explained it. See this. This is a massive or major type of congenital anomaly at the time of birth. Because of that defect around the umbilical ring, the most of the bowels have been herniated outside, and very clear clue is given. See there, it is not covered. Okay, it is not. Let me underline this.
Yes, sir.
It is not covered by peritoneum or amnion. If it is covered by peritoneum, then it would be omphalocele. Because it is bare, it is not covered, it is gastroschisis. Now, what is the management of this? What should we do? If this question is asked like this, okay, you don't need to answer anything. Remember, you are probably a medical officer or pediatrician who is working in the delivery room. So take this baby to the nursery, okay, and cover it. Cover this prolapsed segment of the bowel, okay, with moist pieces of gauzes. Then inform the pediatric surgeon. That's your job. You are not going to do any other thing. And of course, family has to be counseled. So this is gastroschisis. The last question for today.
Sir, pneumococcal pneumonia.
Okay, pneumococcal pneumonia. Okay, fine. So why? What's your reason for that?
Sir, because it looks like pneumonia, like lobar pneumonia, and there is rusty sputum, sir.
Okay, then?
Yes, sir.
Okay. Any other students? Yes. Yes, Rahman, you're saying something?
Kind of tubular breathing is seen in consolidation, like the lung, like consolidation and other diseases. So
Okay.
by X-ray, this is pneumonia.
Okay, good. That is a very good explanation. So both of them are correct. This is a case of lobar pneumonia. So let me explain this for you guys. So see there, fever. This fever is usually high grade fever with chills and rigor. Rusty sputum, very typical of pneumonia, and chest pain. On that area is a pneumonic consolidation. See this part is a pneumonic consolidation. And tubular type of bronchial breathing is very typical of consolidation. He's absolutely right. Okay. So when I put my stethoscope just over this area on the chest, I will hear tubular type of bronchial breathing. Then I'll diagnose this is a case of consolidation. Now after the X-ray, we got our diagnosis. This is lobar pneumonia. Most common causative agent of lobar pneumonia is pneumococci. Now if I do gram stain of pneumococci, what is the finding? Yes, what is the finding of gram stain of pneumococci?
Gram positive diplococci.
Exactly, very good. Okay, Elias, gram-positive diplococci. Now, it is a capsulated organism and it is a very virulent type, okay? It can cause a lot of infection in our body. Pneumonia is one. Another is septicemia or sepsis. Meningitis, one of the commonest organism, actually the most common organism if I consider all the age group, is pneumococci. It also causes otitis media very commonly. Okay, so it can cause a lot of other infection, and especially if spleen is not functioning well, it can easily lead to sepsis and septicemia and then death. But one good thing is we have got vaccination against this particular bacteria, that is a pneumococcal vaccine. It is available in two forms. So it is called conjugate vaccine and polysaccharide vaccine. Now, conjugate vaccine is mainly given for the children. Conjugate means a small amount of protein particle is mixed or attached with the vaccine, okay? Conjugate, so that it will stimulate the T cell when we give, and it has long lasting memory after that. But for adult, okay, if somebody is relatively immunocompromised, for example, some problem in the spleen, or someone are a patient of sickle cell disease or sickle cell anemia, for example, then we can give polysaccharide pneumococcal vaccine for this type of individual. And the treatment is which antibiotic is your choice here? Which antibiotic you want to choose for the treatment?
Sir, macrolides.
Okay. Any other?
And sir,
Penicillin.
ceftriaxone.
Okay, Naimat, I heard your answer. Yes, Rehman Bilal, what is your answer?
It's me, Ilyas, amoxicillin.
Ilyas, which one?
Amoxicillin or
Penicillin.
Okay, okay. So even Dennis is saying, remember this type of question, you can answer, I mean, anyway, okay, but we want to hear penicillin group as the first antibiotic here, because streptococci are still very much sensitive to penicillin. So you can answer penicillin group like amoxicillin, even ampicillin, even amoxi with clavulanic acid, we can accept that